View of the kind, so I will not go into much of the details and I will focus on three things. One is the definition, etiology, and lastly the outcomes. Just a question to all of you. How many definitions have been used in literature to define the acute liver failure? Less than 10, 10 to 20, or more than 20? Those who favor the first alternative, that is the less than 10, please raise your hands. No one. And between 10 to 20? Majority. And what's about the more than 20? So it is second option. So here is the answer actually. There is one paper published, that is the systematic review, acute liver failure, one disease and more than 40 definition. And to be very precise, there were the 41 definitions so far has been used to define the acute liver failure in English literature. Then you can understand how heterogeneous are these definitions and what are our understanding to define this. So there were 103 studies. Those were related to the prognosis of the patients with the ALF, and 87 studies used 41 different definitions, and 16 studies did not report any explicit ALF definition. And the components accounted for the differences in these studies are presence and of the grading of the hepatic encephalopathy. Most of the studies, they say any grade of the encephalopathy is fine, but there are 17 studies, they say, some say that is more than 2 or 2, grade 3 and 4, like that. And intervals between the onset of the disease and the occurrence of the hepatic encephalopathy, presence of the coagulopathy, and pre-existing liver disease. So what is the effect of this kind of the diversity? That it hinders comparability and the quantitative analysis among these studies. That is the main problem. All studies except one included HE as a part of the definition. One study say that only the coagulopathy is good enough. And interval between the HE and the onset of the jaundice, that is quite variable. And you can see that 2 weeks in 3 studies and 4 in 8 studies, 8 weeks, that is the original Trey and the Davidson definition. They say that within 8 weeks it was used most. And the last one, that is according to the ALF study group that is published in by the ASLD, the American Association Study of the Liver Disease. They are the 10 studies. And as far as the diversity in the presence of the coagulopathy as element of the definition is concerned, there are also variability. Some says only the presence of coagulopathy is important, but the majority say that INR should be either equal to the 1.5 or more. And there are variation with the prothrombin time prolongation and the factor 5. All studies say that there should be absence of the chronic liver disease or any cirrhosis of the liver. However, 38 of the studies, they did not mention how they have come to the conclusion that the pre-existing chronic liver disease is not present. So there is high variability as far as the definition is concerned. The first definition, they say encephalopathy in first symptoms. They say first symptoms, not the jaundice, the 8 weeks. And Bernau et al., they say that it is fulminant hepatic failure, another name for the ALF. The encephalopathy and jaundice interval is 2 weeks, and the subfulminant is from 2 to 12 weeks. And the King's College Hospital criteria, that is from the O'Grady's et al., they said within 12 weeks. And they further divide, as you know, that hyperacute, acute, and the subacute. Hyperacute within 7 days, and acute from 8 days to 28 days, and if it is more than that, it is subacute. This is basically, they find a difference as far as the survival without liver transplantation is concerned, which was maximum in hyperacute, and the cause was the paracetamol. On other hand, idiosyncratic drug reaction, they caused the third one, that is the subacute. Despite the absence of the brain edema and the other features, these patients, they have the highest mortality. So they divided into the 3. EASL, they say that acute hepatic failure or subacute hepatic failure, because this is from the B and Tandon et al. They also described initially the subacute hepatic failure. So they wanted to exclude the subacute hepatic failure. So they proposed such kind of a definition. And lastly, That is the definition from the AASLD, that is the ALF group, study group, that the INR equal to or more 1.5 and any degree of the mental alteration in patient without pre-existing cirrhosis and with an illness of less than 26 weeks, that is the 6 months. We all traditionally say when the disease is chronic, it is more than 6 months. The exceptions to this disease is the Wilson disease or vertically acquired hepatitis B virus infection or autoimmune hepatitis, because all these three conditions may have underlying high grade fibrosis or even cirrhosis, but their presentation is just like an ALF and they have the prognostic value as of the ALF. So these are the definitions, but recently the most used definition is those which is proposed by the ALF study group and by the AASLD. So what is the most appropriate definition? That what I personally feel, that is I am going to tell you, that the combination of the coagulopathy and the encephalopathy is unique and is only seen in this setting. If there is no underlying liver disease, coagulopathy and encephalopathy, that is very important. And any degree of encephalopathy indicates a severe life-threatening condition, and disease progression is often very rapid once cognition is disturbed. So the importance of hepatoencephalopathy is there, that it is present, not what grade. Even if it is grade 1 and you are seeing just alteration in sensorium, that is good enough to label that this patient is having the ALF in the absence of the pre-existing liver disease and the coagulopathy. And all whatever is there, etiology, whatever is common clinical, there is always a common clinical picture. And portal hypertension and ascites is usually seen when there is a prolonged course. For example, in a subacute liver failure, what you see in idiosyncratic drug reaction or ALF of the unknown etiology. To me, so I endorse that the definition used by the ALF study group, endorsed by the ASLD, is the best one as far as concerned, and it will be helpful in future studies if we want to compare quantitatively. Coming to the second etiology, East versus West. I think that is the first question that comes to our mind. What is the etiology in Indian subcontinent and what is the etiology in the European countries? I think in our setup, this is the viral hepatitis that predominates, while in the European countries or Western countries, it is the drug-induced liver injury that predominates. And in viral hepatitis, it is the hepatitis A, B, and the E. E virus is the commonest so far. I'll just come to that details. Here you will see that the East versus West. I have reported a few studies from the West, and you can see over here, it is all paracetamol or non-paracetamol drug injury. And you can see that over the 2/3 of the patient of the total, they are because of drug induced. And you see that in Indian subcontinent, we hardly see any patient with ALF because of the paracetamol. But we have the other drugs, but that is a minuscule proportion. And as far as the viral is concerned, that is not the main etiology as far as the Western country is concerned, but that is the main etiology in the Indian subcontinent. And you can see over that approximately 90% of the ALF is caused by the viral hepatitis, mainly by the hepatitis E, B, and followed by A. And if you see that the ALF study group data, that if you see that coming to this is the US data, and you can see that over 2/3 of the patients, they are caused by the drug induced, and the hepatitis B you can see is in approximately 7% only, and others one, they are the uncommon causes. And coming back to the Indian data also, there are the 3 centers which have done these studies in a bigger way. They are from the AIMS, and the Srinagar the SKIMS, and from the PGI data. And here what I have said endorsed by these studies, that the predominant etiology of the ALF in India is because of the viral hepatitis, and the drugs is only 0.6 to the 5.6%. And we have demonstrated that the etiology is changing even in India. you can see that the drug induced has gone up to the 15.4%, and here the E remains the positive, and we also found the viral hepatitis because of the other viruses, and because we are doing the very extensive workup as far as for the etiology is concerned, so our indeterminate group has gone down to the 14%. Let us see what is the change in the Europe, what are the time trends in the European countries. This is the data from the Spain, and here it is 1995. The data before the 1995, you will notice that this is the viral hepatitis that predominates, and after the 1995, that is the drug-induced injury or indeterminate cause that predominates. The viral hepatitis incidence goes down because of the corrective measures they have taken, either vaccination or improvement in hygienic standards. Viral hepatitis, coming to the particular virus, that is hepatitis B virus, it is not necessarily that you always have the novel infection. It can be developed, ALF can be developed if there is a seroconversion with transition from the phase of a stable viral replication or inactive carriers to the viral clearance, or there is a superinfection with hepatitis D virus, or there is reactivation, whether it is because of the immunosuppression or it is a spontaneous one. There are several other viruses also. These are the very well documented case reports, and they cite that there is a cause and effect as far as the ALF with these particular viruses are concerned. Drug-induced liver injury, you can see that there are the two types, the paracetamol, which is the dose-related, and non-paracetamol, which is the idiosyncratic, and you can say that it runs a hyperacute and it runs a subacute case, and there are differences as far as the suicidal and unintentional paracetamol intake is concerned. Once it is unintentional, it runs a acute or subacute course rather than the hyperacute. Again, this US data, I will come to the Indian one because here you can see that the other drugs, non-paracetamol, you can see there are the antibiotics, statins, non-steroidal anti-inflammatory drugs, anti-epileptics, and the anti-tuberculosis. And if you come to the drug-induced liver injury in causing the ALF in India, it is, I would say, 99% or 98% it is ATT induced, and this is excellent study from the AIMS. They say that 63% of the patient ATT was prescribed empirically without definitive diagnosed evidence of the tuberculosis, and the survival rate is quite dismal without liver transplantation. And there are the prognostic criteria. I hope the subsequent speaker will elaborate on it. The last part, that is the outcome. The outcome is better in patients who have the etiology as the paracetamol, shock, that is the ischemic, hepatitis A, and the pregnancy. And if you go see that the other one, where and here is the survival without liver transplantation exceeds 50%. But if you look at the hepatitis B, Wilson's, but Chiari or autoimmune hepatitis, the survival is less than 25%. Therefore, these patients with these etiologies, they require liver transplantation, that is the middle one, in more than 50% of the times, while it is only 6% those who have the better etiology having the better outcome. So this is the table summarizing the same what I have said. Survival, independent survival without liver transplantation is very high, therefore liver transplantation need is very less. But the need for the liver transplantation is high in if there is non-PCM ALF or indeterminate cause. But overall survival is the same if you include the rescue by the emergency liver transplantation. And I think that the liver transplantation has transformed as far as survival in patients with acute liver failure is concerned. Survivals are lesser than the liver transplantation in an elective situation, but over the years you can see that the outcome has improved because of the improvement of the techniques and the other supportive system. And now 1 year survival is close to the 80%, and the 5 year is about 60%. And we have the Indian data from the Medanta, from my friend Sehgal. They say the 1 year survival is around 88%, in 58 patient, those who are transplanted. These, I think the subsequent speakers will dwell upon all these things. Grade of HE, everybody knows, higher the grade, the mortality is high. Etiology I have also said a little bit about the ammonia. Ammonia, these study from the Indian study, they say that the concentration is above this value, the mortality is high, and these patients have the high incidence cerebral edema. They need for ventilation, and they also develop the more frequently the seizures. And the early dynamics, they also predict over the 3 day. If this value is same or increasing, it is very high, and if there is an improvement, it is decreasing, the chances of the survival is very high. So they have the prognostic indication. I think this is the second bell, and this is my second last slide also. I've already dwelled upon it that hyperacute, they have the better chance of survival. They said that it is because of the paracetamol. Our population was 90% of the viral hepatitis, and we found that this phenomena also exists in patients with the ALF due to the viral hepatitis. Survival is better with the hyperacute as compared to the subacute or acute combination. So ladies and gentlemen, I would like to summarize. I've discussed that the definition proposed by the ASLD or ALF study group is the most appropriate one. It takes account of everything, and the etiologies east and the west, they differ, viral versus the drug induced, and the outcome, paracetamol, hepatitis A virus, HEV or ischemic, they have the good prognosis, and the survival is good even without the transplantation, while it is worse in patients with ALF due to the non-paracetamol induced drug injury, hepatitis B virus, autoimmune hepatitis, Wilson's and Budd-Chiari, and the other prognostic factors include that the hepatic encephalopathy, ammonia, and so forth. Thank